a very important topic for me personally, and it's just one of the core issues that we face in the intensive care unit. So I want to try to make it applicable to all disciplines and all types of primary care people, because really there are lots of opportunities to find these patients earlier in the game, and that's really what this is all about, improving the early recognition of sepsis. So my goals are to make sure that we're talking the same language terminology-wise, because I see lots of misuse of these terms in the charts, and I think step one is let's get on the same page with what we're talking about. We're going to talk about the magnitude of this problem, and then the core message is let's change when the word sepsis is spoken, I want your brain to have a different picture than what you have in your head right now. We're going to talk about the Surviving Sepsis campaign and its efforts to improve recognition and treatment of these patients over the last 12 years or so, and then talk about how we've implemented these recommendations not only in the ICU and the emergency room, but have expanded it into the regular floors. If you ask the general question, what does the human body do when it is infected? What are the earliest signs that there is a change from the normal healthy patient? And certainly vital sign changes is as basic as it gets in medicine. And these recommendations, this definition was established in 92. So 14 years ago, we knew about this inflammatory response syndrome. It's very basic. Temperature, abnormal temperature. Either you're hypothermic or you have a fever. Heart rate is fast, greater than 90 beats a minute. At rest, respirations are fast, greater than or equal to 20 breaths a minute. And a white count that's either elevated or depressed. And those are just four basic ways to recognize early that a patient is changing. That doesn't tell you what it is. I mean, you can run up a flight of stairs and have two of these be abnormal in 10 seconds, but this is the beginning of the diagnosis. So next slide is the three core definitions that I want you to leave here with. Sepsis is a patient who has 2 or more SIRS criteria and any infection, either an infection that's obvious or an infection that you just suspect but you can't really put your fingers on it. And that's it. I mean, that's what sepsis is. And it's early in the game. It's the beginning of the diagnosis. Step 2 is severe sepsis. And it is patients who have sepsis, again, 2 or more SIRS criteria, an infection, but we're adding organ dysfunction. And organ dysfunction is the concept of that, the way you think about it, the way you recognize it, is a key part of recognizing sepsis. And we're going to talk a fair amount about that pretty quickly. And then septic shock is the thing that all of us know, and that we know what that looks like. We know what it is. It's severe sepsis with shock, hypotension. And the caveat is that these are people who still have low blood pressure despite a standard fluid bolus. And that's another take-home message, is what is an adequate fluid bolus for a suspected infected septic patient. You see it's all across the board. You pull charts and you'll see 250 cc's of saline, 500 bolus. But the literature recommends 30 mLs per kilo. So if you're 80 kilos, that's 2.4 liters. And that's just to begin with. One of the biggest changes in sepsis care is the front loading of volume resuscitation in a big way. And if you're 100 kilos, that's 3 liters of saline. And not over 8 hours. Get the fluid in these patients if they are starting to show signs of hypotension or organ dysfunction. So the second part of this slide is this progression, the continuum of sepsis. And that's the other thing that will allow us to do a better job, is we don't wait for the train to pull in the station with the septic shock, DIC disaster with ARDS. We can hear the whistle blowing a lot earlier. And you know, sepsis is way earlier than my world. I mean, nobody with simple sepsis needs to be in the ICU. Their mortality is almost zero. Most of them have viral illnesses. You have a mild case of the flu. You're going to have 2 surge criteria. You're going to have an infection, even though it's a viral infection. They're self-limited and they get better. But when you cross over to severe sepsis, your mortality that was less than 10, maybe less than 5, is now, you know, increased to 30%. I mean, your mortality's jumped 4 times by having the beginning of organ dysfunction. And I'm going to have a chart on the next slide to tell you all the different things that meet the definition of organ dysfunction. And then these patients go on to develop septic shock. So finding these people at the point of shock is a disservice. You've missed your opportunity. Your mortality has jumped from under 30% to 50%. So you're costing people lives if you don't recognize it until it gets to shock. The pathophysiology of what's happening in the organ tissue beds for these people is the point of early recognition, because they all have dehydration, and and the sick ones will go on to develop the organ dysfunction and shock. And you put bacteria in the capillary system, and you're going to get inflammatory cells that release mediators of inflammation, and it causes dysfunction in the endothelium. So pretty quickly, the plasma leaks out of the vessels into the tissues, causing tissue edema, and that's why they're universally dehydrated. I mean, I see these charts that say sepsis, renal dysfunction, dehydration. It's like, God, I mean, that sepsis, severe sepsis is endothelial dysfunction and fluid leak into the capillary. It's part of the syndrome. You don't need to define it further. It's what's happening. So you're going to have less perfusion of the tissues because your endothelium is allowing all your plasma to leak out. And then you're going to have microthrombi causing clots that block blood flow to a lot of the branches of the tissue as well. So you've got ischemia and poor perfusion in the tissues happening very early after the bacteria get in the bloodstream. And these patients, I mean, you look, if you could see their capillaries, you'd go, wow, they're sick. You look at them, they look fine. It's happening below the surface. You don't realize it unless you look for the subtleties. So the next slide is the organ dysfunction slide. And I think this is not what, I mean, I want this to be in the back of your head when you're thinking about a sepsis patient. And this is not going on in a widespread way like it will be or should be. When you think about organ dysfunction, just the easy way is to think about from top to bottom. I mean, the brain. I can't tell you how many septic patients that I get from the emergency room or the floor, and the #1 diagnosis on the sheet is ALOC. Because it's almost universal. A severe sepsis or septic shock patient has neurologic dysfunction, and it may be subtle. It may be they can't remember little details early on at home, or they're just completely not themselves. And particularly the elderly, when they come in from the nursing home or their family bring them in, they'll say, you know, mom's just not mom. There's just something going on. And that's an innate part of the neurologic dysfunction of sepsis. Pulmonary-wise, it's generally an oxygenation problem. I mean, we measure SATs, and if the SATs are low, that's obvious, but the PF ratio, the PO2 divided by the FiO2, if that's less than 300, that's pulmonary dysfunction. And you look at the slide, if your PO2 is 100 on what is probably 4 liters nasal cannula oxygen, 33% oxygen, you're right at the cutoff of a PF less than 300. So these are subtle oxygenation changes that aren't really kind of picked up as being something really bad. Certainly if you have jaundice or you have shock, you quit making urine, you've got low platelets, or your INR is elevated. These are all examples of organ dysfunction that if you're not tuned into it and looking for it, you miss. You see a patient with fever, you see they have an infiltrate on a chest x-ray, maybe their white count is 14,000, but you're not picking up that they've got pulmonary organ dysfunction and they're on oxygen, and then their platelet count is 89,000 and their creatinine is 2 and they've made 10 cc's of urine over the last hour. So next slide is the kind of a breakdown of which organs are most likely to fail in this setting, and you know, heart and lung are at the top of the list. I mean, you either have shock or shortness of breath or hypoxemia. Those are the most common examples of organ dysfunction. And then that's followed closely by renal and neurologic, and then the coagulopathy of sepsis. I mean, the magnitude, you know, when I talk to lay people, they all know about heart attacks, they all know about strokes, but they don't know anything about sepsis. But in this slide, this severe sepsis comparison with other major diseases, on the left is cases per 100,000. There's more cases of severe, certainly way more than colon cancer or breast cancer. And then in the right slide, the severity of it, the mortality of it in deaths per year, it's equivalent to acute MI. So it's very common, and it's very serious and very deadly. Next slide is the listing of the breakthrough kind of sepsis treatment options earlier in the 2000s. And not all these have panned out. I mean, Xigris was the first to recognize that these microthrombi are occurring in the organs, and we're going to treat it with this kind of anticoagulant type therapy. But once early goal-directed therapy came into play, the benefit of Xigris was just not, it was no longer seen, and it's not even on the market. The ARDSNet protocol, ventilator protocol for ARDS, is something we use regularly, still alive and well. Insulin control has gone from not much control to very tight control to kind of somewhere in between. Corticosteroids are still a kind of controversial topic, but when it's all said and done, the only two real lasting improvements from this wave of hopeful improvements is early goal-directed therapy and early antibiotics. And those are the things that we want to make sure we are doing, because they have stood the test of time and are still frontline recommendations. This is from Manny Rivers' initial early goal-directed therapy article, basically looking at 60-day mortality for septic shock patients. And the control group that got a lot of treatment, got early antibiotics, got a central line, had their CDP pushed to a target level, had their mean pressure pushed to a target level. Without the checking of the venous oxygen saturation and targeting that, there was about a 20% difference in mortality. A 57% mortality dropped to 44% with early goal-directed therapy. And basically for us, it's put a central line in and achieve 3 goals. Number one is, you know, they're dehydrated. We've seen why they're dehydrated. We want to get their tank adequately full. And that's defined by this protocol as a CDP that's 8 or better. So you put a central line in, their CDP's 4, you just start running the saline in wide open until you get to 8. And when you get to 8 or greater, off of a ventilator, or 12 or greater on a ventilator, that's the definition that everybody's agreed on, means that your circulatory tank is adequately full. Step 2, which is really step 1A, and that is, as you're filling the tank, keep the perfusion pressure, the blood pressure, at an adequate level. And that's defined as a mean pressure of 65. So those are just basic ABC critical care things. You know, get the volume adequate in the circulatory system, get the blood pressure up to a perfusion level. And then step 3 is what makes the protocol different. Draw a sample of blood from a central line in the superior vena cava, measure the venous oxygen saturation. If it's less than 70, try to get it to 70, and that's with either packed red cell transfusions or an inotrope like dobutamine, something to to help just improve the oxygen delivery to the tissue. So that's what we do in the ICU. We just want you to help us find the people who need it. So who needs it? The two entry criteria for River's original study were people who develop septic shock, which is the need for vasopressors after that standard fluid load, that 30 mLs per kilo of fluid load. But it used to be 20 to 30, so for us it was just 2 liters. Get 2 liters of saline in them. Now with the 30 ml recommendation, it's 2.5 to 3 liters. But you can't, or if you have a central line and your CVP is already 8, then okay, the tank is full and the patient still needs Levophed, they got shock. But you don't want to classify somebody as having shock if their blood pressure normalizes with your volume challenge. So you want to try to get that, and we've had a lot of meetings with ED to make that a normal process. When that septic patient with pneumonia has organ dysfunction and is confused and their lactate is greater than 4, they need 30 mLs per kilo of saline. And they're doing it. We're getting patients now that this is their 3rd liter of saline. Now, they've already had 3 downstairs. And the other trigger is people whose lactate is 4 or greater. And that subgroup of people, they haven't developed shock yet, but they have enough of this organ dysfunction, this tissue bed hypoxemia that is creating lactic acid, and it is your real early warning system that the patient is about to fall off the cliff. So these patients look fine. I mean, you hear that all the time. Dean, their blood pressure's okay, their white count's only 13,000, they look fine, but their lactate's 6. And I'm like, they're not fine. Shit, I'll take it. So the Surviving Sepsis campaign has kind of been the orchestrator of the recommendations over the last 15 years. Multidisciplinary organization. They've had 3 different updates of their recommendations, 2004, 8, and just recently in 13. And their goal is to reduce mortality from sepsis, not only in the United States, but worldwide. And there's a huge number of lives that can be saved if we do these simple things that are either not expensive or not a special equipment. Their latest they've broken it down to early resuscitation bundles. And they want these things to be accomplished in the first 3 hours and the first 6 hours. So we're on the Surviving Sepsis campaign slide, the blue slide. These are kind of measures of quality, these kind of core measure things that we have in other things. These are the core measures for sepsis. If you have a patient that meets the definition of severe sepsis, has organ dysfunction, has an infection, measure the lactic acid level. Draw blood cultures before you give antibiotics, but give the antibiotics fast, ideally within the first hour. If you're writing antibiotics for a newly febrile patient, the stat should be somewhere in your order. You can't routinely give antibiotics and let them hang 8 hours later. That's not okay. And then find the people who need early goal-directed therapy and give it to them. The people who have shock, the people who have a lactate greater than 4. And then the goals within the first 6 hours are basically the goals of early goal-directed therapy. Get their CVP to 8, get their mean pressure to 65, get their SCVO2 to 70 or greater. And that's it. I mean, give them fluids, give them antibiotics, put a central line in, and do the protocol. I mean, it's not rocket science. This is the subtle but real way to show us the next slide, the mortality by time to antibiotics. And down at the bottom, it's 1, 2, 3, 4, 5, 6. Those are hours it takes to get the initial antibiotics in versus mortality. So every hour that you delay, a few more people that are going to die. It's not a massive number, but it's hard data from many different sites that the longer you delay, the more people die. And this is another way to look at it. It's an odds ratio from times 0 of when they get their first antibiotics and in 1 hour increments. And every number is higher because the longer you delay, the more people die. Now, this is what's in most people's heads that trained 10 or more years ago. septic shock with purpura and PIC. We all know what that looks like, and we know how bad that is. But I want that to be out of your head, and I want this to be in your head. This is what severe sepsis looks like. Somebody who's getting a little extra oxygen. Somebody who otherwise looks pretty normal. They're not, don't let the appearance of their clinical condition let you go astray because you don't think they're that sick, or you think they need to be sicker to be in the unit or sicker to be in the hospital. It's not true. So we saw as an ICU in 2004 that the Rivers Early Goal-Directed Therapy study had been out for 3 years, and we weren't doing it, and nobody was doing it. And we said, this is crazy. We're gonna do this. This is the core of what we treat in the ICU. So we've had this been going on for 10 years. Meeting with the emergency room, upgrading their recognition, getting them to draw lactic acid levels quicker, having my own guys do it, being willing as an intensivist to get a phone call that says this lady who looks fine with this oxygen is lactate 6. Can I send her to the unit? And I'm going to put a central line in within 10 minutes after she gets there. These are all cultural change things, but they happen. And we've been doing this a long time. And now we are taking that next step in the last year and a half and having sepsis be recognized on the floors. Will the docs and the nurses on the floors pick up on who has these subtle signs and find them quicker? So this is a table that we just presented at Society of Critical Care's meeting this 6 weeks ago in January, where we have 5 years of our early goal-directed therapy. The top layer going across are the total number of patients screened starting in June of 2007. 552 patients were screened for sepsis the first year, then 606, then 707, and 855, and then the last year 1,300 people were screened, meaning patients with new fever that the nurse pulled out the screening sheet and said, oh, they have 2 surge criteria, and they have an organ dysfunction, let's send a lactic acid. So we've had a nice up-ramping of the total awareness. And of that, the next row is the total number of patients who are candidates and get the order for early goal-directed therapy. That's up to 400 to 500 a year, 2,100 patients over this 5-year period. Of those people, 72, 75% or so meet the targets that we're trying to do with the early goal-directed therapy. So, I mean, these are unheard of numbers. I mean, the hospital, the guy who is the chairman of the Society of, he's been at the Society of Critical Care head, and he's also the head of the Surviving Sepsis campaign. His own hospital doesn't have numbers that are anywhere close to this. So we are doing something very special in Lakeland, but it can even get better if we expand the awareness, particularly in the primary care setting. So right now, Cerner has implemented a kind of an automatic way to before it was a nurse, generally an ER nurse or an ICU nurse, had to think, oh, this patient might have sepsis because of a new fever, or maybe they got a new tachycardia, or they're on more oxygen than they were, and they have to get the sheet and fill it out. Now Cerner is monitoring in the background constantly, and they're sending out these 2 different alerts. The surge alert is for any patient who develops 3 or more surge criteria in a short period of time, 24 to 48 hours. It dings. It may be nothing. It may be that they rolled over in bed and got short of breath, but it may be that they've got the beginning of a sepsis continuum problem. And then the other alert that's a more serious alert is 2 surge criteria and 1 new organ dysfunction based on maybe lab, maybe the total bili is now up, or maybe the platelet count that was 150 is now 80. They don't always mean sepsis, but they are in the umbrella of the people that have sepsis. So that's going on. If you've worked in the hospital, you've got these phone calls. That's what's been going on. And the nurse, when the floor nurse sees this alert, they call the critical care assessment team. They come to see the patient. They're very well versed in the things that septic people have early on. They're battling doctors. I mean, they call the doctor and say, look, I've sent this lactate and it's 6.2 and the patient's temp is 101 and they're breathing 28 times a minute and their white count's 17,000. And then sometimes it's okay. What's the next step? That's a trigger to send them to the unit. Other times it's like, why are you bothering me? This patient's fine. I saw them 3 hours ago. They look great. They don't need to go to the unit. Quit drawing all this lab on my patient. And we're still not where we need to be. But if their lactate's 4 or greater, if they have shock and they need these fluid boluses and they're not responding, or they are not quite there, but they've got a lot of comorbidities. Their baseline creatinine is 3.5, or they're on home oxygen anyway, or they've got some underlying cardiac dysfunction. I'll take every one of those people. I mean, there's so many of those people that I'm going to get anyway in shock and put them on the ventilator now. I'd much rather do it up front. This is an added slide that is not in the original submission, but it's using procalcitonin in addition to the lactic acid. Because when a lactate is high, it's not always sepsis. I mean, there are many other things that cause a lactate to go high. But if you're going to blow it off, you better be as sure as you can, because you're going to lose your opportunity to deliver this 6-hour early goal-directed therapy that's only beneficial right up front. There's no proven benefit if you do it the next day or 14 hours later. It's an early treatment that is shown to work when it's given early. A procalcitonin can be a tiebreaker. And this is a lot of words to basically say people who have active systemic infection, septic shock, positive blood cultures, they have a high likelihood of having a procalcitonin that's 2 or even much higher, 8, 10, 20, 100. 2 seems to be the cutoff. If you're below 1, it's pretty strong evidence that the chance of that being a true bacterial positive blood culture sepsis patient is low. So maybe your lactate's 4.5 and you think it's just liver dysfunction and they've got cirrhosis and they otherwise don't have much surge criteria and the procalcitonin is 0.5, that's a way to say, okay, we looked and it doesn't look like this is a septic patient. But if it's 8, now I've got a high lactate, a high procalcitonin, surge criteria, organ dysfunction, ba-boom. Next slide is, what is the big deal about the lactate? And the big deal is your earliest way to know who is seriously ill and has a high chance of continuing to worsen if you don't jump in there. And that's a different mindset than we have. I mean, I trained where you don't even get in the unit until you're in shock or have DIC or something bad. But the biggest improvements in the big diseases, acute MI, stroke, sepsis, are understanding how it progresses and catching it early and intervening early. I mean, the door to balloon time is a big deal. The quick TPA for stroke early. Find them. Let the ambulance people know about it. Let people at home know about it. So the earlier you catch it, the earlier you intervene, the better the outcome's going to be. So it is a hugely important early warning system that counteracts that unbelievably ingrained thought process, but they look fine. The patient looks fine. Okay, if they're fine, their lactate's 0.5, okay. But if they look fine and their lactate's 8, no good. All right, the other point I really that I see every day is the lack of desirable terminology and documentation of these. And we'll look on the left. I see this all the time. I get a patient from the emergency room, and here's my list of diagnoses. Chest x-ray, infiltrates, increased white count, volume depletion, tachycardia, fever, renal insufficiency, ALOC. You know, I mean, it's like looking at somebody with cellulitis of the leg going, it's erythematous and edema, and it's warm, and the white count's up. You know, I mean, we can go beyond the description and use the terms that this means. I mean, this same person in our unit is going to be relabeled. This is a community-acquired pneumonia, and this patient has severe sepsis because they've got 3 SIRS criteria, and they've got 3 organ dysfunctions. They've got acute kidney injury, which is a renal dysfunction, hypoactive delirium, the neurologic dysfunction of sepsis, and hypoxemia, of the pulmonary dysfunction. So you look at that second list, the first list, you think, well, that patient's not too sick. They've got some routine stuff. They need some antibiotics, some IV fluids. The second list is, oh my God, this patient's got a 30% mortality and has a high risk of progressing to septic shock. So if you label it for what it is, they're gonna get identified quicker. They're gonna be treated more appropriately for their problem if you just name it right. Because on the right now, on the left is just give them antibiotics, but on the right they're getting stat antibiotics because we know every hour we delay, they have a higher mortality. And we're not just going to give IV fluids, we're going to give a 30 ml per kilo standard bolus for this patient. So these are the subtleties of how we're doing it in a lot of ways and how we can improve how we're doing it. So the take-home messages are, there's a continuum from simple sepsis, low mortality, to severe sepsis, to septic shock. And each step is filled with more danger and more mortality. And it's in many ways predictable. If you intervene, sometimes if you don't intervene, the patient's kind of quit getting worse. But a lot of times if you don't intervene, it just keeps getting worse. So we need to use these terms, and we need to know what they mean. We need to have a high index of suspicion, even in people who don't look sick. And this is very important. If you're working urgent care or you're in your clinic, that lactate can really be a big tiebreaker. That lactate and even that procalcitonin can really help you pluck people out of that you were going to send home, or people that from the ER are admitted to the floor and who are going to end up coming to me 8 hours later. Just use the tool. You wouldn't think of not drawing a troponin if somebody had atypical chest pain, and you don't think it's cardiac pain at all. Are you not going to draw a troponin? Really? I mean, everybody draws a troponin. I mean, the lactate should be the same way. I'm going to draw the lab that helps me decide if it's a big deal or not. So the window for early goal-directed therapy is in the first 6 hours. That's why it's imperative to pick up on this early. The start time is the time of the first lactic acid greater than 4. Sometimes people say, well, that first one was 6, but I gave him some fluids and rechecked it and it's down to 3. Well, that's good, but they were 6, and they can benefit from the central line and the SCDO2 push because there's articles about it helping. Proactive floor nurses and CCAT nurses can really make a big difference in getting people into the ICU earlier. And ultimately, our motivation is just to find patients who meet the criteria, find them early, treat them early, and have as many of them live as we possibly can. And that's really what it boils down to.